Here's a summary of our clinical vignette from Monday. Feel free to pause the video and take a look at this patient's symptoms again. It's important to highlight that our differential for this patient's presentation is indeed hyperthyroidism. So moving on to her ECG, it's very tempting to diagnose this right on the spot, but we do want to go through our steps. For detailed teaching on the 6 steps that we're about to do, please refer to our ECG basics video. So first thing we always want to do is we want to start with rate. We're going to use the 300 method here because it seems like a pretty regular rate. So we're starting here and we're going 1 big box, 2 big box, 3, 4. So between 4 and 5, very close to 5. So let's call that about 60 to 65 beats per minute. The rhythm. We're going to use the paper method to figure out this rhythm. So we're going to take a blank piece of paper and line up 3 successive R waves. 1 there, 1 there, 1 there. And then we're going to slide this over, whoops, and see if it matches. And it does match, and that means that our rhythm is indeed regular. Next thing we want to do is look for P waves. We do indeed see these characteristic bumps, and they are always attached to a QRS. So when it comes to P waves, we're going to say yes. We're going to put a little star here because we notice that there's similar bumps for these that aren't attached. Next thing, QRS. If we zoom in, we can indeed see that the QRS here is 1, 2, 3. Less than 3 boxes wide. So we're going to call this normal. Okay. Next thing we do is the PR interval. Again, we want to zoom in and make sure that the PR interval is less than 5 small boxes. 1, 2, 3, 4, 4 to 5. So that is normal, less than 200 milliseconds. So that is normal. And the next thing we look at is the ST segment. And we can look after every QRS complex and notice that the ST segment is roughly on the isoelectric line. So we're going to call that normal as well. Okay, so moving on to our next slide is the summary of our findings. Okay, so we see everything is normal except P waves. We notice that we have P waves, but we have multiple P waves that aren't attached to a QRS complex. And so our interpretation of this is atrial flutter. So what's the pathophysiology of atrial flutter? We know that it's a single reentry circuit originating in the right atrium. What's important to distinguish for A flutter is the waves are morphologically similar. Every bump looks roughly the same. The AV node is very important in that it suppresses the conduction of every single flutter wave of going back into the ventricles, which means that the ventricular rate is significantly slower. Okay, so for example, the atrial rate may be around 300 beats per minute, while the ventricular rate will be about 150. Okay, and what's causing that morphological pattern of those P waves is a signal inside the right atrium circling around and around and around and around. And every once in a while, one of those signals will pop through into the bundle of His and the Purkinje fibers to give you that characteristic QRS. So interpretation tips for A flutter. It's important to realize that the atrial rate will be very fast. We'll have atrial tachycardia anywhere from 200 to 400 beats per minute. You'll get a characteristic sawtooth pattern of the isoelectric line as that electrical activity cycles through the atria. It's best seen in leads 2, 3, and AVF, and if you look in V1, those flutter waves will often be inverted. The ventricular rate will always be slower as the AV node will block transmission of repeated atrial contractions. Now the block is often in a fixed pattern. If it's a 2-to-1 block, the ventricular rate will be 150, 3-to-1 will be 100, 4-to-1, 75, and on and on and on. Importantly, every once in a while you'll have variable block. So the ratio will shift between 2-to-1 and 3-to-1, or 3-to-1 and 4-to-1, etc., etc. One cool interpretation tip that you could do to sort of enhance the isoelectric line is take your ECG tracing and flip it. So this, if you notice here, if you look at all the writing, is upside down. And that sawtooth pattern between every QRS becomes very obvious. So let's look at a few examples. Here's an A flutter with a high-grade AV block. High grade meaning the numbers are actually higher, the ratio is higher, 5:1 up to 8:1. If we look here, we see 1 QRS and then 2, 3, 4, 5, 6, 7, 8. There's an 8:1 ratio. If we look here, here's a QRS, 2, 3, 4, 5. So this is a 5:1 here and an 8:1 here. And so there's a variable block, but it's also high grade because it takes a long time for a QRS to go through the AV node. Here's an A flutter with variable block. Let's zoom in here. So here we have a 3:1 block, and here we have a 5:1 block. 3:1, 5:1. Okay, so this is what we were talking about before, not having a fixed ratio of transmission through the AV node. And here we come to a tracing with 2:1 block. Let's again zoom in to the rhythm strip, and we see here's our QRS complexes. And here we see flutter waves right here. And there's our 2:1 block. If we zoom out, we can see in every lead and throughout the entire rhythm strip that ratio stays consistent. So, takeaways for A flutter. It's very important not to mix up A flutter with atrial fibrillation. Check out our atrial fibrillation for more detailed teaching on that. Hints for interpretation. Try flipping the ECG paper upside down. It'll be much easier to see that classic sawtooth pattern of A flutter. A flutter waves will be visible before each QRS complex and will have the same morphology. That's incredibly important because in AFib, those waves will either not be visible or will be very chaotic. Thanks very much for watching, and we'll see you in the next one.